To dive into the next session, we're fortunate enough to have Rosin Devlin along with us today. So Rosin is going to be covering the topic of substance-induced psychosis. So obviously a really multifaceted topic and one of interest, I'm sure, to everyone that's in attendance today. So Rosin's an advanced trainee in the Child and Adolescent Psychiatry Service for South Western Sydney Local Health District. So Rosin has worked for South Western Sydney Mental Health Services since 2011 in various inpatient and outpatient settings. More recently, she has worked for Liverpool Early Psychosis Intervention Program and the Out of Home Care Whole of Family Service, which is a new partnership between FACS and South Western Sydney Local Health District. Rosin's recently presented at the Royal Australian and New Zealand College of Psychiatrists Congress on her work and research with this new service. These experiences have recently led to her focus working with children, adolescents and their families. She currently works for the Park House Infant, Child and Adolescent Mental Health Services in Liverpool. Prior to working for the LHD, Rosin worked for the NHS in Belfast, Northern Ireland, following graduating in medicine from Queen's University, Belfast. I'd like you to join me in welcoming Rosin up to the podium. Thank you.
Thank you. Just that last bit sort of explains the funny accent and where it comes from. I think people are always a bit intrigued. So I just want to thank you for coming along today, for giving me the opportunity to speak about a subject I'm really passionate about, which is the mental health of young people. I'd like to acknowledge the traditional owners of this land who have allowed us to gather here today and talk about youth mental health, and also pay respects to elders past, present and future. I'd also like to acknowledge Joanna's story. It really struck a chord with me, having worked in the mental health service at Liverpool for the last 6-7 years. And when I was compiling this presentation, it really, I was looking through recommendations and guidelines and was thinking to myself, yep, these are the recommendations, these are the guidelines in a perfect world, but there are gaps in our services, and I do expect some questions and some frustrations being expressed here today in trying to access acute mental health care for young people. It's incredibly difficult, and we do, I suppose, what happens in the system is we forget about people like Joanna, because those are the people that fall through the gaps. Look, talking about substance-induced psychosis in young people, it's a bit of thinking is changing around it, and I think I can't really talk about this topic without talking about early psychosis intervention, and that's going to be the crux of the presentation. Just get my clicker. Okay. So what is psychosis? Well, psychosis isn't actually a disorder. I think it's a feature of more like underlying disorders such as schizophrenia or bipolar affective disorder. It's characterised by hallucinations, delusions, disordered thinking and abnormal psychomotor behaviour, and what that can look like is agitation or complete withdrawal and inability to connect with the outer world. When we think about substance-induced psychosis, the definition currently in the DSM is a person has to display one or both of either hallucinations or delusions, and that is associated with acute intoxication from substances or recent substance use and current withdrawal state. It's usually self-limiting, and we do have, if these symptoms persist longer than 1 week, it would raise concerns that there is something more than just a substance-induced psychosis. There are multiple psychoactive stimulants or psychoactive agents that can cause substance-induced psychosis. Most of them are commonly known: cannabis, cocaine, methamphetamine and amphetamine. Those are the big three that we kind of think about, but also things like alcohol, the more neurosynthetic agents like chronic. I'm sure some of your young people have spoken to you about this, and also alcohol and corticosteroids, which are actually what doctors prescribe to patients who have some kind of inflammatory illness. The recent National Drug Strategy Survey in 2016 looked at the patterns of substance use in our young people, and it was actually quite interesting. Substance use appears to be downtrending. For the rates of cannabis use is going down in our young people. It's sitting around 15%, but it is overwhelmingly the choice of illicit substance use in young people. Methamphetamine use is actually going down despite what the message that the media are portraying. But what was interesting from this study is it did identify that people who choose to use methamphetamines are more commonly using the more purer forms, that is crystal methamphetamine, or otherwise known as ice, or base. And we know that they have more toxic effects on the brain than the older methamphetamines. This survey also produced some data on young people and the characteristics in the population that are using substances. The most interesting, I think, statistic for me was the use of substances in the LGBTIQ community. I know as a service, I don't think we're the most sensitive to the needs and issues facing that community, and I think it was a really important point that survey highlighted. I think we have to be more knowledgeable, have more training on the issues facing young LGBTIQ people, because almost 50% of those surveyed from that community were using substances. And what we do know is, accompanied with that, people from the LGBTIQ community have higher rates of mental illness and higher suicide rates than those in the general population. So I think that's a really important statistic, and I think it's something that our service providers really need to think about. We need to be a bit more savvy as to what young people are experiencing from that community. The other interesting aspect from that survey is it highlighted that the rates of substance misuse in unemployed young people was much higher than those who were employed. Why that is, I'm not sure. Is it the substance use that's preventing them from accessing employment, or is the employment and the issues facing young people who are struggling with youth unemployment, is that what's driving them to use substances? And the last point that I find quite interesting from that survey is that 15.3% of young people are using drugs to improve their mood or stop themselves feeling unhappy. And I think that's a really important statistic. I think all too well what we see as clinicians and as a younger doctor entering the field of psychiatry, you just focus on the drug use and you think, well, you need to stop using drugs, when actually, why is that person using drugs? What has went on in their life? I think we are getting better. I think we are becoming more trauma focused, and certainly my work with the out of home care and whole of family team really brought that message home to me. I didn't meet one parent or child who was using substances that didn't have some form of trauma history. So in terms of what does this all mean? Well, what I think about the years 12 to 24, they are crucial in psychosocial development of young people. It's where they find themselves in the world. It's where they carve out their future direction, their future goals, their career plans, and also there's a lot of pruning, synaptic pruning going on in the brain, which helps young people enter adulthood and assist with emotional regulation and other cognitive processes. But when we introduce a substance during that period, what does it do to those brain pathways that are helping people develop the skills to regulate themselves and their emotions into adulthood? It's causing a massive disruption. When I looked at the burden of illness in terms of mental health, for young men, it was the third highest disease burden of illness. For young men, 44.9% were identified as having mental disorders were identified in 44.9%, and for young women 38.4%. These statistics are even higher for Indigenous men and women, and the reason for that disparity is felt that mental health issues and substance issues are much higher for our Indigenous population. It's not the evidence isn't really clear about how many people presenting with psychotic symptoms would be classified as a substance-induced psychosis, but it is approximately between 7 to 25%. Though the research and the evidence is really quite patchy. When we think about drug and alcohol use and mental illness, the two comorbidities, I think I came across this slide and I thought it's actually really, really highlights the cycle and how the two issues are really intertwined. There's this constant debate over the chicken and the egg, which comes first? Is it the substance use? Is it the drug use? And does the drug use cause, or is it the mental health issues? Do the mental health issues cause the substance use, or vice versa? And really, I think it's really impossible to separate. I think, what we do see though is once the two come together, they have this codependent relationship and a cycle. You have a young person will use substances to make themselves feel better, but then they get the horrible withdrawal effects. They get the crash, the burn, and then the urge to use more substances comes in again. And really what this cycle highlights is that we need a multifaceted approach, a two-pronged approach to helping young people address both their drug and alcohol and their mental health issues. So what are the substances that cause the most issues for young people in terms of mental health comorbidities and particularly psychosis? I think it's the issue around cannabis. The evidence is clear, and I almost every week in my work with the early psychosis service, I came across questions from young people about cannabis, medical marijuana, the current research, the recommendations, and I think we have to be really pragmatic as clinicians in answering those questions. A young person is not going to accept no, cannabis is bad and walk away from your session and be happy. I think we have to skill ourselves in what is the evidence out there, what are the risks to this young person if they decide to use substances or not, and present it to them and respect that they have autonomy in whether they decide they wish to continue with their drug use or not. But we have provided them with that evidence so that they can make the right the decision that's right for them. It's a eternal debate that we can have with some of our clients, but it's become such a big issue, and there's so much information out there on the internet and so much misinformation that I think it's an issue we have to be prepared to discuss with our clients, and we have to be knowledgeable about this issue. We can't just say drugs are bad and you can't use them because you'll get sick. So what is the evidence around cannabis? Well, what we do know is that in people who have a vulnerability for schizophrenia, so that's someone who has a family history, they may have a neurodevelopmental disorder such as a hypoxic brain injury, ADHD, or a learning disability, they are more likely to become psychotic if they use cannabis. The other thing we do know that is cannabis use can also accelerate a psychotic episode in someone who may or may not have been at risk of developing schizophrenia as well. So not only can it precipitate a psychotic episode, but it can also accelerate the onset of that episode. What we do know is as well around cannabis, there's clear evidence to show that people who have had a psychotic episode and continue to use cannabis, they're at more risk of further relapse, and they're also their recovery rates are limited or impinged by their cannabis use. There was a study into consumers who experienced a first episode psychosis and participated in an early psychosis intervention program. Those who abstained from substance use did achieved huge functional gains through the program after 30 months. Those who continued to use cannabis didn't really achieve very much gains. And I think that's a really important study. I think we can't prevent we can't unwind the past, but what we can show our clients is if you have had a psychotic episode and you continue to use substances, it will impact on your future and your recovery. And what do we mean by psychosocial functioning and recovery? Well, we talk about things like homelessness, employment, greater issues around increased risks. So, for example, there's a lot of stigma around someone having a psychotic illness and they might be a violent person, but actually what the evidence shows is the risk of violence is higher if that person continues to use substances. And when we have someone who is at higher risk of becoming violent, it also brings into things like incarceration, isolation from friends, family, peer groups. I think I can't really do this talk without talking about ice and the ice epidemic in southwest Sydney. The media have really sensationalised this, and we hear about it day in, day out in the media. And I absolutely love this cartoon because it's talking about the ice epidemic, but also the alcohol issues that are in our society, and that has totally been neglected by the media. And it was funny, I was chatting to one of the dual diagnosis CNCs in southwest Sydney, and he was commenting how we really are missing the point a lot with some of our interventions. We're not asking about alcohol use. We're not seeing the huge problems that alcohol can cause for young people and older people as well. And I think this cartoon really sums it up. So what about ice? What is going on with ice? As I mentioned, we do know now that methamphetamine users are tending to use the more purer forms, such as crystal methamphetamine or base. And we do know we've known from the 60s that psychostimulants can induce psychotic disorders. What we do know is that a high proportion of people, when they stop using methamphetamine, they will rapidly recover, but there is a small percentage of people who will have persistence of their symptoms. When the rates, though, of methamphetamine-induced psychosis are still unclear, and it's but there is a lot of research ongoing in the field. What we do know, though, is that if someone has a previous history or a vulnerability to psychosis and they use methamphetamines, they are at higher risk of becoming psychotic. In terms of the people who present in the community with methamphetamine induced psychosis, a lot of people present with some subclinical mild symptoms of psychosis, so they don't necessarily come to the attention of mental health services or the emergency departments, and it's not really clear what that's about. You know, is the substance causing those symptoms, or is this some kind of prodromal pre-psychotic state that if they were to continue their substance use, they'll end up in a full-blown state of psychosis? And most people who've used methamphetamines that I've encountered that have presented to the emergency department, often they have had those previous experiences where they could sense that they were starting to think a bit oddly, behave a bit oddly, but still had that insight, and then stopped using and entered into their crash phase of the drug use. So it's still not really clear, and again, it's an area for further research. What we do know, though, is that there's no real evidence to suggest we should be medicating people who are presenting with intermittent psychotic episodes while they're using methamphetamine. What can be helpful is treating the acute episodes. So often in the emergency department, you will get a patient in who is agitated, displaying psychotic symptoms, and you may use sedatives or antipsychotics to try and treat that acute agitation and those acute psychotic symptoms. And then you'll come back in 9-10 hours and they'll be things will have completely resolved. And that intervention was needed at that time. I think the big question for a lot of us is but should we continue with something more regular? Should this person go home on a regular dose of antipsychotic? And so far the evidence really isn't clear on that, and there's no evidence to suggest that we should be doing that, though some clinicians may choose to do that. I think the best intervention that we can provide is educating our young people, linking them in with services. Abstinence is probably the best treatment in terms of reducing methamphetamine-induced psychosis. And I think it's been breaking down the stigma associated with methamphetamine use. I think the media have a lot to answer for in terms of why people are not coming out and accessing services, because no one wants to be labelled a drug addicted ISA addict, no one wants to be labelled a junkie, but those are the headlines. And I think a lot of methamphetamine use is going under the radar. A lot of very intelligent, high functioning people are using methamphetamine and continuing to live normal lives, and they don't want to be labelled with those labels that we are seeing in the media. So this sort of leads me on to talk about the current treatment recommendations, and there's some really excellent documents out there, and look, I can't really, they're very detailed and they're really quite user friendly, and they give really key points on working with young people who have comorbid illness. And the guidelines, I'm a bit biased because I'm from the UK, so I always have a little bias towards the NICE guidelines, but they are really excellent guidelines, and they have a wide range of guidelines on working with various different physical and mental health issues. They have excellent guidelines on assisting clinicians working with young people and assessing comorbidity. When I say comorbidity, I mean drug health and mental health issues. Also, Origin are big leaders in the field, and I suppose in Australia we really pride ourselves on our early psychosis work, and that was led by former Australian of the Year Pat McGorry down in Melbourne, and they have also produced not only the Australian guidelines for early psychosis intervention, but they've also produced recent guidelines on the it's called 2 at a Time, so it's working in with comorbidity. And it's a guide for mental health and drug health clinicians in supporting young people. There are other guidelines I did come across that are more directed to people working within drug health services and increasing their skills and their knowledge around mental health issues. Unfortunately, I can't remember off the top of my head, but I'm pretty sure if you Googled it, or Stevie Barnes is here, she probably knows. She's our youth comorbidity CNC. But those also look like really, really excellent guidelines. So the current recommendations across the board, across all those three guidelines that I showed there, is that we have to have an integrated approach. We can't have, gone are the days where we put people off and label them and send them off to whatever service. The two services, drug health services and mental health services, need to work together, and ideally we need to have a more cohesive relationship with each other and have training together. We need our mental health clinicians to be savvy about drug health issues, and we need our drug health clinicians to be savvy about mental health issues. And I think there are still issues with that. There are systemic difficulties around patients and services trying to refer to each other, but the guidelines are really clear when it comes to working with young people who are presenting with early psychosis symptoms. We need an integrated approach. And with that comes an open door policy. We cannot turn away young people because they're using substances. I think that is one of the biggest take-home messages for me from these guidelines, is that there is no exclusion criteria. So from the reason, I suppose, so early psychosis intervention programs are now they're part and parcel of working within health districts, but the reason these services were established was because young people were not accessing treatment in a timely fashion. And what we do know about psychosis is the longer the duration of untreated psychosis, the more impact that has lifelong on the young person. It causes significant disability, both physical and psychologically, to the young person, and socially as well. I read a recent, last year there was an article produced in the British Journal of Psychiatry commenting on the focus on risk assessment in our profession, suicide risk assessment and violent risk assessment. Actually, our patients are more likely, 100 times more likely to die of a preventable physical illness than they are of suicide. And I think we really need to shift our focus and think more holistically when we're encountering a young person for the first time. So the reasons why young people struggling to access services are stigma and fear, which I think we all know about, that the services aren't really designed for young people. You have to go to this outpatient clinic and you have to see this doctor who you've never met in your life. You've probably not met very many doctors in your life, and it's a really scary experience. And you've got other priorities. You've got uni, you've got to meet up with your friends, you've got your HSC exams. Why do you want to take a day off school or uni to go and see this person for something that you're not really convinced that you might have? You might just all be in your head. Well, that's what you think anyway, and that's a common issue that we face. So the early psychosis services are designed now to be a sort of outreach. They can go to the client, they can work with schools, they can work with universities and families, and try and make life as easy as possible for the young person, because it's hard enough going through what that person is going through, never mind having to battle all these other systemic difficulties. The other issue that young people face and why they weren't accessing services is what I was talking about in terms of we need to be integrated, and it was frustration around divided services. They don't want to have to go to drug and alcohol and then have to go to the psychiatrist appointment and then have to go see their private psychologist. It's just too much out of a young person's life. And as Michael Carr-Gregg was talking about technology, like young people want things instantly. They're used to having their smartphone. They can just go and they can look at what they want on their smartphone and get the answer. They can engage in CBT on their smartphone. So, it's a huge deal for a young person these days to have to divvy out their time in order to access all these different services, and it's confusing as well. The other issue is around lack of awareness or lack of knowledge of what services exist out there. And I think, I'm here today and I'm seeing all these different tables, all these different organisations, and I've worked in Southwest Sydney for almost 7 years, and I didn't know half of what's out there in terms of supports for young people. So we really have to be champions of our service. We really have to sell ourselves and let people know that yes, we want to see you, we want to support you, we're here, our door's open to you. And the other issue that was limiting people accessing mental health services was also lack of referral to services. So I suppose that's one message I want to give, particularly to GPs or psychologists that are maybe here today, is that we're not fussy about what's on the referral letter. We just need to know the salient points, and I'll give you the referral points towards the end of my presentation. But if you are in any way concerned or suspicious, please refer on. And we don't expect you to manage this alone. We are here to support you. And if it isn't an organising a service like the Early Psychosis Intervention Programme, Headspace are also doing an awesome job in this field and doing that very, very early work with young people. So really, ideally, early intervention, we want to get in there before the psychotic episode has happened. Unfortunately, the way the services in this area have been established, though, that isn't always the case, but we are very grateful for the establishment of Headspace, who have actually opened their doors to that early psychosis, ultra high risk stage of psychosis, in terms of getting in there and monitoring, and then referring on to somewhere like the Early Psychosis Programme if they are concerned a young person is developing a psychotic episode. The reason we want to get in early before the psychosis has developed is we may be able to delay the onset of the psychotic episode, and as I mentioned, if we can reduce the duration that someone has an untreated psychosis, that has better outcomes for that young person. What we know, as I said, delaying the duration of untreated psychosis is really important, because it does increase, or the longer a person has an untreated psychotic episode, it increases the risk of developing a more enduring mental illness or disorder. So what I'm primarily thinking about is schizophrenia. It also can decrease their ability, their journey to recovery in terms of their psychosocial functioning and physical health. And as I previously mentioned, there are also reduced life expectancies associated with a longer duration of untreated psychosis. Assessments should be timely. We shouldn't delay. If you suspect a young person may be at high risk or experiencing early psychotic symptoms, they should be seen within 24 to 48 hours. Really, primary healthcare professionals should feel competent and confident in picking up on these warning signs. And the other aspect of that is be aware of the referral process and have a low threshold for referring. I think people worry, what if they reject the referral? It doesn't matter. All you can do is refer. You go with your gut feeling. So basically, treatment recommendations for early psychosis intervention circle around the Pat-McGorry model, which is a staging model of psychosis. Today I'm just going to focus on stage 1 really, because I think that's what most people struggle with. I think that's what primarily community clinicians and support workers are seeing and are a bit unsure about and who to approach and where to access support. I think stage 2 is pretty obvious when it does occur. I think quite a few of us may have seen a young person who is experiencing psychotic symptoms, and usually it's pretty easy to get help at that stage. But it's stage 1, I think, that causes a lot of confusion and uncertainty for people working in this field. So stage 1 is really classified as the prodrome, which is the period pre-onset of psychosis, and usually it is a retrospective diagnosis. We don't say it's a prodrome until we know that person has actually had a psychotic episode, but often we can look back and we can say, yeah, there was a definite change leading up to the psychotic episode. What we can do is, though, we can potentially identify people who are ultra high risk, which is the term that's been coined by Origin. And what ultra high risk means is a person who has a definite family decline in their function over the previous year, either chronically low functioning or has had clear periods where they've had about a 30% decline in their functioning. And what we mean is that person, what that looks like clinically is the person's become a bit isolated, withdrawn, a bit immotivated, not really engaging in school or their studies as to what they were, requiring a bit more, prompting by the family. What are you doing with yourself? And often it can be just put off as typical teenage behaviour. They're in that teenage slump. They just want to sit all around all day playing video games. And this might be the stage where young people might start using cannabis, because they have this sense of just not feeling right, but they can't put their finger on it. And maybe if I try this, I might feel a bit better, and it might help me engage with my friends a bit better. So that's something to really look out for when you're working with young people, is what were they like a year ago and what are they like now, because there's something just not right here. And then the other aspect to it is what we call an attenuated psychotic symptom. So these are really mild or non-specific symptoms. So things like, the person's a bit more suspicious, just a bit odd in their behaviour towards you or towards their family, developing some odd ideas, odd thinking. The thing I think about is they might, decide, all metal containers are and metal devices are contaminated. I'm only going to eat with a wooden cutlery. Or they have some odd ideas about communication, about the internet. The government can download your data, which is true, but a little bit more of a preoccupation about these issues, and they're just really subtle and not enough to really diagnose a delusion, but there's just something not right there. And often at this stage, young people get diagnosed with possible depression, possible anxiety, and another long list of various different things. No one can really put their finger on it. And it's these young people that may be at higher risk of going on to transition into a psychotic episode. The other syndrome that is classified in the guidelines is brief limited intermittent psychotic syndrome, known as, I think it's BLIPS, which is quite a mouthful, but essentially when I think about drug-induced psychosis, which is the topic of this lecture or this talk, that it kind of fits into that. Those people presenting with those brief self-limiting psychotic episodes would meet the criteria for BLIPS, and they are people who are at risk of developing full-blown first episode psychosis. So people with BLIPS usually have quite frank psychotic symptoms that resolve by themselves and are less than 7 days. So a lot of people who are using, a lot of young people using methamphetamine or cannabis may meet criteria, and if they have a family history, they should be referred on to either Headspace or the Early Psychosis Intervention Service. So what does this mean? Why is this important? Well, actually, when we look at the data, the research, about 12 to 25% of young people who were deemed ultra high risk within 12 months have converted to a first episode psychosis. And you think, well, you can't really, so they were going to develop it anyway. But if you have them linked with a service, there is less, they are getting treatment, they're being monitored, there can be quick intervention, very prompt intervention, and you're reducing the duration of untreated psychosis, as well as you set up that therapeutic relationship, you set up that alliance, that you've provided the psychoeducation around what could happen, given education around early warning signs, and as a result we might be able to provide intervention at home. It mightn't result in this young person having to be sectioned under the Mental Health Act, be brought to ED and locked in a ward for 4 to 6 weeks. We actually might be able to get in their home, try and maintain as much normality and grounding as possible, and treat them at home with the support of their friends and their family. And that is one of the big goals of early psychosis intervention services. Gone are the days where we want to remove people and have them in a locked ward with an assessment, a formal assessment and diagnosis and medication, and treat them until they're 100% well. We don't want that. We want to keep young people at home because we identify how traumatic it can be for a young person to be removed and have their autonomy removed and be taken away from their family. And it's also traumatic for the families as well. However, there is controversy around this as well. You know, are we mislabeling young people? They re-looked at the statistics more recently, and actually there's been a drop in transition within the first 12 months. I think it's a drop between 10 and 19%, and there were a lot of questions around this. Are we mislabeling people? Are we diluting the pool of people who are considered to be ultra high risk because they're not actually ultra high risk, and therefore transition rates are reduced? Or are we getting in there and preventing the transition to psychosis? That question remains unclear. But there is a lot of criticism to this model and labelling people as ultra high risk. So what can you do? I suppose I've already sort of said refer. And, what are the referral pathways? There's the Early Psychosis Intervention Service within the local health district, or there, if you're just not quite sure, the other option is Headspace. And often Headspace is a more comfortable option for young people. I think the thought of being referred to an acute mental health service will freak a lot of young people out. So Headspace is a good option. If you're just not quite sure, you've got someone you think might be high risk, and you're pretty sure they're not psychotic at this stage. There is evidence for omega-3 fatty acids in reducing transition to psychosis in those ultra high risk patients. So if there's any GPs out there, don't be afraid to prescribe some omega-3 fatty acids. You probably can buy them over the counter as well. And also referral for things like CBT. So Headspace can provide CBT, and also there's lots of private psychologists that can provide CBT. So what this might do is those people with the mild psychotic symptoms, this may help them think about their symptoms, challenge their symptoms, and delay transition to frank psychosis. It may improve their social functioning. So if they've been sitting at home in their bedroom not communicating with people, CBT can also help with getting them out of the home, engaging more socially and vocationally. And it also may reduce the need for antipsychotics, which I haven't really spoken about. And the reason I haven't really spoken about is I don't think we should be rushing to prescribe antipsychotics in young people. I think that is a specialist. That is for a specialist to do. I think, because antipsychotics, along with them come really, really horrible side effects. Most commonly metabolic syndrome with the newer agents, and I think we have to be really aware that we could be causing harm if we decide to just start an antipsychotic before we even know what's really going on for this young person. And the other thing that we can do is supportive counselling, and consider other causes. You know, could this be some other underlying physical issue? Have we checked their thyroid? Have we checked their B12? Have we done an MRI? Could this be something mimicking psychosis? So that's what we can do at a primary level. And as I said, there's no evidence to suggest antipsychotic use in those ultra high risk patients, although they have been used, I think, as a last resort. The CBT and referral to a specialist service is what's recommended. Really, if you are feeling forced to provide an antipsychotic, we would recommend one of the newer agents. Aripiprazole, where now is our gold standard at Liverpool. It's got a weight neutral effect for most clients, and it seems to work really well for young people with a first episode psychosis. And the rule is go low and go slow. Don't feel rushed, don't feel pressured. And I also want to highlight the role of carers and family. They are so crucial in supporting young people, both with their drug health and their mental health. I think I read a research study. If a family member at home is using substances, the young person is at higher risk of using substances. So I think if you have a family and you can identify a substance use issue within the family, it doesn't do any harm to bring it up with maybe the parent or the older sibling and say, hey, you know, there's also these services for you if you're interested, because that will have a knock-on effect for the young person and will help them with their recovery from substance use. The other aspect where families are really crucial is they help young people access treatment. They will pick them up from school, they will pick them up from uni, they will bring them to their appointments. They, you know, if a person feels that their parent, wants them to have a treatment, they're much more likely to go along with that treatment after other parents has probably been making decisions for them for the last 16 years. And also family are really crucial in psychosocial recovery. Often if the family can support that young person with their vocation or educational goals, the outcomes are much better for the young person. But along with that, we need to consider what this is like for families. It is an incredibly scary time, and a lot of the work of the early psychosis team involves working with families. We think of grief, possibly one of the parents may have had a psychotic illness. We think of the disruption for their family, fear, is my child going to be impaired for the rest of their lives? Will they always be like this? And we know that all these emotions, they come from stigma. They come from what the media portrays, the violent psychotic killer, and that is a parent's worst fear. That's often the question we get asked when we're trying to explain psychosis to parents and families. I think it's really important though to also inform parents of the statistics. 25% of patients will have a first episode psychosis and fully recover. 50% may have a relapsing condition, but maintain good baseline recovery, and then there will be 25% who will have a more enduring, persistent symptoms through their lifetime. And I think if you can give them that 25% hope that they're a young person, this might be the only time that they can experience it. That can work. That can be really, really helpful for families. I think we have to be hopeful, and we have to leave our own stigma at the door as well when we're communicating with families. So there are lots of recommendations, psychoeducation, psychosocial support. Maybe, we have to think about young people, families having to take time off to work with the young person. Do we need to think about, a temporary carers benefit and helping them with that? Referral for family therapy in some cases, accessing cultural support. I think particularly in Southwest Sydney, we've got a very unique, diverse community, but with that comes challenges, and cultural differences in approaching and perceptions of mental illness. So use our multicultural workers, our transcultural mental health teams, and our Aboriginal mental health service as well. They're crucial in working with families. And also there are community organisations and NGOs that we can tap into to support families. So just the early psychosis intervention programme in Liverpool, so that's the service that I previously worked for. So they take referrals from age 16 to 25, and I'm not going to go through what they do, but they have a wide range of things that they provide. They have a psychiatrist that works full-time with their service, as well as a psychiatry registrar, which would be someone at my level. And they provide continuity of care for their clients. So if their client has a psychotic episode and is admitted to hospital, they follow them on that journey. They don't hand them over to the inpatient team. They manage them both inpatient and outpatient, and they're a 2-year programme. There's a big focus on metabolic health due to the issues around metabolic syndrome in antipsychotics. I think most I think in the first 6 months of treatment with something like olanzapine, I think the statistic is 8 kilos a patient can gain in weight through initiation of that medication. So it's something that we really, really take quite seriously there. And they also have social engagement programs. They have group programs where they will do activities as a group to try and improve that young person's psychosocial functioning and engagement, because it's a very traumatic experience being psychotic when none of your friends have been psychotic, and it's trying to reintegrate people and help them with their recovery. So in terms of referral, COMET is usually the main intake line, and I'm sure everyone here has COMET's access number, but each district has their own early psychosis service. So we have the Liverpool Fairfield based at Liverpool Hospital, Bankstown, and then there's the Camden, Campbelltown and Wollondilly MacArthur Mental Health Youth Team. They're slightly different. They're not a specific mental health early psychosis intervention program. They take a wider range of clients with different mental health issues, but they also have do early psychosis work within that service. For clients that are under the age of 16, I suppose the ICAM service is also a referral source, and ICAMs will take referrals directly from school counsellors and GPs and paediatricians, whereas EPIP will only take through the COMET service or another service within South West Sydney Local Health District. So if you've got someone that's under the age of 16, I think the first port of call would be ICAMs. And then the other service I mentioned is Headspace. They're doing a lot of work with early psychosis intervention as well. And these are some drug health services out there. There's some really awesome websites that can support young people and their families in terms of accessing drug health services. I think there's quite a few people here from the youth health services, and they can be really helpful in providing support to young people for both their physical and mental health. So there's Flight at Carramar, Trackside in Campbelltown, and the Corner in Bankstown, and they also have affiliations with South West Sydney Mental Health Service, so they can activate a referral to the early psychosis intervention programme. I'm just going to mention the website Reach Out. I think Michael Carr-Gregg mentioned it. It's an awesome website. There's tools on there for young people, parents and teachers and support workers in supporting young people with various issues that they may face: drug and alcohol, internet, lots of different things on their website. It's really resource rich and really good website to have a look at. I was also looking at Youth Solutions, which is in the MacArthur area, and they have a lot of information on what mental health services are out there and drug health services are out there for young people. And just the Hearing Voices Network is a really good peer support organisation which has a lot of success, very recovery focused. It's about patients having their voice, having autonomy, and being able to share their experiences with each other, because I think it's that peer support is vital in terms of recovery and sustaining hope for the future. So my take-home messages are really like, feel confident. If you are worried about a young person, just refer. Don't delay referral. The best advice we can give our young people is that if they are at risk of psychosis, ongoing substance use is going to dramatically increase the risk of developing something like schizophrenia, and it is going to have huge physical and psychological consequences for them as they enter adulthood. And also involvement of families and carers and helping them feel empowered, but at a time when they feel at a loss. Okay, and that's it.
So thanks so much to Rosin for that was an extremely thorough presentation, but delivered in a very efficient and concise way. I definitely learned a lot from listening to that. So I'm sure that we have some questions in the room. So I'm happy to take some questions.
Yeah,
so
I'll try.
on the spot there. So who has a question from that presentation?
Yeah, my son was diagnosed with schizophrenia in 2009. Was helped by early psychologist. The good thing about that help is that they went home.
Yeah.
Because he didn't want to go to hospital.
Yeah.
And was there for 2 years. And now, since 2011, up to now, we didn't have any episode. And my question is, did he stop completely the drug? Is that it didn't happen new episode because of stopping completely the drug? Or
Is this substance use or his actual antipsychotic medication?
Antipsychotic.
He stopped his medication?
And it's also stopped
Using drugs. Yeah, look, it's the thing with mental health is we can never predict, but we know what we can do to reduce the risk. So the fact that your son has been able to recover and return to his baseline, his normal life, the fact that he's decided that he doesn't want to use substances anymore, he is doing everything in his power to reduce his risk of developing another psychotic episode. What we do know though is at times of stress, people can be more vulnerable. So self-care is really, really important. Things like looking after your sleep. If you're noticing that you're becoming a bit more anxious or down in your mood, letting your friends and family know, going to speak to your GP, accessing a private psychologist to support with that. But he's now been how many years free from symptoms?
2011.
Yeah, so that's a really awesome recovery. And as I said, 25% of people will have one episode and make a full recovery with no further episodes. So hopefully he's in that 25%. Yeah.
I see a lot of people with early symptoms. I think about it because I'm not very experienced with mental health issues.
Yeah.
Okay, my previous experience was in the ER. So, are there any ways or some method to identify people who are high risk?
So there is I think it's the CART. There is a special scoring pro forma, and it's accessible through Origin. They do recommend that you do training for it, and it helps identify early those who may be at ultra high risk of developing frank psychosis. So it's this CAA or it's escaped me, but it's on the Origin website, and also Headspace I think as well use that tool. So if you are worried, if you are suspicious, I think you can contact the Comet team and even just speak to someone over the phone to see if it warrants assessment by their service, or you can refer to Headspace if it's less urgent, and Headspace can also I believe do an assessment as well. What's that? Sorry?
You made a comment earlier when you talked about suicidal young people and psychosis. I just wanted to know if you could explain that
Okay, was it about? Was it around how our patients are more likely to die of preventable physical illness than they are to suicide? Yeah, this is across a lifetime. Obviously, there are people who are young people who are experiencing psychosis are at high risk of self-harm and suicide, and it's something that we do take seriously. But I think the way services have been designed is that they've been so risk focused that we've forgotten about everything else, and those are the things that are really important to the individual. And actually, recent research has come out that it's almost impossible to identify who is at risk of suicide. The risk assessment tools aren't very accurate, and there are a lot of we miss a lot of people who may be at risk of suicide based on these risk assessment tools. It's obviously really important to be checking in with families and young people about suicide, but I suppose my comment was more that we shouldn't get bogged down in that when we're developing services and looking at caring for young people with psychosis. We have to look at the bigger picture in terms of their recovery. So yeah, but it's still a really relevant issue. I'm not saying don't consider it. The youth suicide rates in Australia is incredibly high, and are these people that were maybe prodromal or starting to develop a psychotic episode? We don't know, but we do need to still consider suicide risk. And if that is the case, the other access referral option is the emergency department. There is 24-hour staff and mental health staff in the emergency department, including a psychiatry doctor as well. So, I would, if you were concerned whatsoever about a young person being at risk of suicide or risk of harm to their family or to other people, refer to the emergency department. I wouldn't wait.
Guys, we're right on lunch, but we might have time for one final question if anyone else has got a question that they wanted to ask Rosin. I have one if everyone else does. Just in regards to the, you talked about the range of drugs in regards to some of the incidents of drug-induced psychosis and cannabis in particular.
Yeah.
I just wondered about any new incidents around synthetic cannabis, so spice and things like that.
Yeah, look, I think the research is, there's not much research and these agents keep changing, so it's really hard to do research in that field, but we have seen, just my own clinical experience, a lot of presentations of synthetic cannabis use induced psychosis, and also other agents, and what we're finding is the level, the degree of psychotic symptoms and the duration can actually be much worse than cannabis. Yeah. So it is a big, and also our patients don't realise, you ask them, are you using any drugs? And they're like, no, I bought, no. And then you find out that they've been smoking the stuff they bought in the shop, but they don't view that as being drugs. And actually it's just as detrimental to their mental health as cannabis.
Well, thanks so much for a terrific presentation.